Hi, my name is Harsh Vivek Singh. I am presenting today the finger and thumb dislocations. It's a short, basically, synopsis of the topic. Basically, when tried to do this topic, I thought I should divide into two things: MCP dislocation and phalanx dislocations. So MCP dislocations are dislocations of the metacarpophalangeal joint, as you all know, usually dorsal, caused by fall and hyperextension. Phalanx dislocations are common traumatic injury of the hand, basically involving the proximal or the distal IP joint. So basically, that they are mostly caused by fall, and the phalanx mostly by any traumatic injury. And the X-ray and the pic I have included for the same. So further going into types of dislocations, finger dislocations can occur at the distal IP joint, proximal or metacarpophalangeal joints. The proximal interphalangeal joint is the most commonly dislocated finger joint among all the finger and MCP dislocations. Injuries to the MCP joint often occur most commonly in the index finger, followed by thumb. Dislocations of the DIP joints are commonly traumatic and often complicated by fracture and soft injury, as we have discussed before as well. So dorsal dislocations are common than the volar and the lateral dislocations. So there are further three types of dislocations if you want to go into that. So including X-rays, the first X-ray, second, so we got the MCP, DIP and DIP dislocations in the X-rays. Further, we can divide into simple and complex. Simple, when there is no interposition of the volar plate or sesamoid bone. Complex, when there is interposition of the volar plate or sesamoids. It can result in Baynard deformity in phalanx dislocations and Kaplan-Leon if in MCP dislocations. In the X-ray, in the two X-rays, we can see the difference. So the simple and the complex dislocations. So you can see the volar plate coming in between the complex. So this and the simple dislocation, there is no volar plate interposition between the dislocated phalanx. It's just a basic anatomy of the factors which stabilize our joint. The proximal interphalangeal and distal interphalangeal joints are both supported on all four sides by similar soft tissue structures, we all know, which include volar plate, collateral ligaments, and the extensor complex. We have discussed in our last teaching as well. It's not going into much details. The figures are pretty much descriptive of the same. Now coming to for the thumb, I just included this slide to basic idea that in the thumb FPL tendon displaces ulnarly to create a noose. So this is basically going more complex into the mechanism of dislocations. While in index finger, the flexor tendon can displace ulnarly and lumbricals can displace radially. So how they put a noose around the dislocation next. Now coming to the further slide, mode of injury, we have discussed sports injuries are the most common cause for dislocations of PIP and DIP joints of fingers, most commonly in basketball and football, basically contact sports with the ball. Occupational injuries, fush because of a fall, we have discussed that mostly MCP joint dislocations are common because of fush and of course traffic collisions. So this is a famous figure of, I think it's Joel Abrid. He plays for Philadelphia. So you can see his dislocated finger. It was, I think, last season, I think. Yeah. Now the presentation can have multiple presentations. The symptoms of dislocated finger: crooked, looks crooked because of dislocation, obvious. Swollen, of course, pain is the main thing. Injured finger may appear pale, and the first figure I have tried to make out. It can have bruising. You can see the first figure, the first one. It can have numbness. We can always make out from the examination, or it can have break in the skin, like open dislocation and cut where the finger was dislocated. In the third figure, we can make out. So I have included all the figures which we can see: crooked, swollen, bruised, pale, and of course if there is open dislocations. This is most common presentations. Diagnosis, of course, it's clinical. The finger is crooked, swollen, pale, bruised, open, or it can be radiographic. So it can be confirmed by history, physical examination, and of course, radiographs. X-ray can show joint space widening, interposition of volar plate in terms of seismoid, complex and uh, simple dislocations. Now, coming to the management, do not simply pull a dislocated finger because we don't know it's a simple dislocation or it's a complex. If in the again the same figure, the complex, we can see there is a volar plate interposed between the dislocated ends, so not a good idea. So management for simple dorsal phalanx dislocations, close reduction and body tapping, one of the procedures. We can reduction with force, directed volarly and inflection. The figure we can make out from that. Body tapping can be continued for 3 to 6 weeks if it is a stable reduction, or we can put extension block splinting if it's unstable. So reduction, body tapping for 3 to 6 weeks, and extension block if if it is not stable. So figure A is body tapping, then extension block, the DND. Management for the complex dorsal phalanx dislocations, of course, close reduction with hyperextension of the middle phalanx followed with palmar force. So this is a different mechanism compared with the simple dislocations. And of course, open reduction if close reduction fails or more than 40% articular surface is involved. And dorsal approach is the most common with incision between central slip and lateral band. Coming to MCP dislocation, I found this very useful slide, which serves a basic, I think, easy purpose. So common is dorsal dislocations. It can be simple, complex, simple, close reduction, if stable, body tapping, unstable. We have got two. We can this is for MCP. If unstable, we go to the other side. Same as for the complex one, surgical reduction. We got two, volar and dorsal is more simple, bit safe, commonly used. The disadvantages, of course, mentioned in the slide, volar plate exposure, delayed healing. So this is for the MCP dislocations, bit different from the finger dislocation management. Coming to the complication slide, so we can get flexion contractures. It may develop but can resolve with therapy, so we need a hand therapy for that. We can have swan neck deformity, if this is most common seen in complex dislocations. Extensor lag, of course, if the volar dislocation, it's understandable. Joint stiffness, it's a long, it's like a chronic complication, can develop due to prolonged immobilization and no hand therapy. And of course, post-traumatic arthritis due to repeated attempts at close reduction or prolonged dislocation or prolonged immobilization as well. So I think to end this discussion, I got an X-ray for a double dislocation, very rare, very rarely seen. Yeah, I think that's the end of my discussion.